Okay, good afternoon, everyone, and thank you for inviting me to this amazing event. Thank you for giving me this chance to present my case in front of these wonderful audiences. Um, okay, I'll move on right to my topic. Okay, that was a nice event again. Okay, so this is my second time in France, and the last time I visited France was 19 years ago. It was in the year 2005, September. And that's my family picture. And fortunately or unfortunately, all of them are now dentists with different majors. And I come from South Korea, the capital city, Seoul. It's a very nice city, so I really recommend you guys to visit here at least once. More the better. And this is my hospital where I work, Seoul National University Dental Hospital. This is my colleagues. I'm on the right. And then my name is Dr. Songjin Kim, and it's really nice to meet you guys. So back to my topic. My topic today is details in digital implant rehabilitation and the key to patient satisfaction. I'll first give you guys three keywords. First, be a good listener. Second, be the mastermind in your treatment process. And third, focus on the basics. My topic will focus on these three topics, these three keywords, and I'm presenting you before my presentation so that you guys can focus on these keywords. So the first case I want to present is I titled it A Lifetime Smile. If this reminds you of Megagen, the quote, I think that's just a coincidence. And this is the initial panoramic radiograph when I met the patient. And guess what? This patient, he's only 32 years old, and he had suffered from lymphoma. Now his lymphoma stage is now it's in a stable stage, but he's still with his temporary prosthesis and haven't had his definitive prosthesis yet. And some of the patient details is that he lives 4 hours away from my hospital, so he has to come every 4 hours just to meet me. And moreover, he just got hired and got a new job, so he can now only come on Saturdays. And his first impression and aesthetics is the most important thing for him right now. And if we look at the problem list, first aesthetics, the temporary prosthesis with him right now has obviously a lot of problem. Um, it has the expanded dental arch and the crown length. It was too excessive, too big for the patient. And second, he had poor oral hygiene. He told me that it was difficult to brush his teeth because he was worried that the temporary prosthesis will fall out when he brushes. And every time the temporary prosthesis fall out, he needs to come to my hospital, and it takes 4 hours. And third, the problem list function. The temporary prostheses were always fragile and it can easily fracture. And there was only one implant in the right maxillary posterior area, which was prone to fracture. So we set a treatment plan for him to place 2 new implants on right maxilla and remove the 2 exposed implants on the mandible and replace it with 3 implants besides it. This is the picture here. And however, the treatment for the mandible was postponed at patient's request. So we moved on to maxilla first, 2 implants on the right maxilla. It was neatly placed using a surgical guide. And we move on to the provisional prosthesis stage. We decided to reinforce the interim prosthesis using a resin fiber. It was because of the aesthetic issues and because he was a young patient and he just got a new job, aesthetics was very important. And instead of using a metal wire, we instead using a resin fiber that was aesthetic and it looks like a tooth color. Provisional prostheses were delivered to the patient and it was made as a screw retain type. And the reason why I use screw retain type is because it does not use cements. The patient was always concerned of cement loss, and because this does not use cement, the patient does not have to worry of the temporary prosthesis falling out. And moreover, because this type of prosthesis, screw retain prosthesis, has more thickness of resin, it is more strong to fracture than the cementation type. Also, because now we can check if the patient can actually brush his teeth and get his oral hygiene maintained by changing to screw retain provisional prosthesis. So this is a provisional prosthesis delivered into the patient, and we still have the exposed implants on the mandible. However, we have a much more nice appearance of the patient here with just the provisional prosthesis. Now the patient's telling me that the other teeth look so nice, and now the exposed lower implants looks more noticeable, and now he wants to go on with the mandible surgery. And moreover, he told me that because he got a new job, he doesn't want to be without teeth after surgery. So I told him that using digital implant planning and guided surgery, we will fulfill your needs. So planning was done to remove the 2 exposed implants and replace it with 3 implants nearby and with immediate reloading. The immediate reloading was prepared based on the position of the patient's existing prosthesis, so the surgical guide was designed to make the same prosthesis again, and prefabrication of the provisional prosthesis attached to the temporary titanium cylinder was made before the surgery. So the implants were removed nicely, and the other implants were placed at the position as we planned. So what I did on the chair side was intraoral relining, and what we did on the lab side was finishing and polishing the temporary provisional prosthesis. So if we look at the pre-operation photo on the left and the post-operation photo on the right, the patient goes home with almost in a similar situation that he came to the clinic that day. We'll move on to the definitive prosthesis stage. First, the abutment selection. Let me remind you of the initial state of the patient. There are a lot of problems here, including that there was titanium and zirconia abutment with supragingival margin, and it was standing out, and we do not want this to happen again. And if we check the provisional state, the provisional restoration's crown length was very adequate when smiling, so we had to use pink porcelain or at least pink staining on the gingival side to represent the gingiva and reduce the crown length. This, in other words, means that we cannot use zirconia abutments on the anterior area, even though it can be very aesthetic. And that's why we decided to use anodized titanium abutment on the anterior area, and the articles reports that pink anodized abutments represent a good aesthetic alternative to zirconia hybrid abutments, especially in mechanically challenging situations, and it's much more better in aesthetics than the unanodized titanium abutments. So the anodized titanium abutments were selected in the anterior region for the patient. And we'll move on to the intraoral and facial scanning. A dentulous ridge was scanned, and it was scanned with the scan body once more, and the provisional bite registration was used so that the patient can keep on with his provisional bite and the vertical dimension that he had. And facial scanning was done, and the T-zone area drawn on the screen was used as the alignment region because this zone does not change as the patient, even though the patient's expression or facial expression changes. That T-zone stands still, so that's why we use this area as the alignment region. And for jaw motion tracking, and the jaw motion tracking was done before we do jaw motion tracking, recording mandibular movements in clinical situations. We have to make these attachments before we go into the clinic. And we have to check that there are no interference in lateral or protrusive movements, because if there's interference, it's going to definitely result in a wrong data, and it's going to extend your chair time. So we want to check this onward before we go into the clinic. And we have the digital Facebook on the left and bite fork on the right. The bite fork was used to record the maxillaris position. And the patient's movement were recording the right lateral, left lateral, protrusion, and mouth opening in orders. So digital Facebook was done, and it was the prostheses were designed on the virtual articulator. And moving on to the digital smile design, I think this is a very important slide that I want to mention. This is very important because I think this is why we need to be mastermind in our treatment process. Digital is really good. It's going to give more information to the dental technicians, and it's going to help the dental technicians to make a good prosthesis. And I agree that good dental technicians can make good prosthesis. However, we need to give more information to them. It's because the dentists are the people who meet the patient for the most time. Dental technicians usually don't have the chance to meet the patient in face to face, so we have to give them the information needed. We have to give the impressions how the patient actually is, so that the good technicians can make better prosthesis. So we checked that the definitive prosthesis design was changed from the provisional state, and we checked the facial scanning data, and the definitive prosthesis were delivered. and this is a much nice impression compared to the initial state. So we have a facial appearance that looks much better, a facial profile better than the initial state, and the facial photo, and this is the last panoramic radiograph we have. And moving on to my second case, I titled it Rebuilding Smiles and subtitled What Only Implants Can Do. It was a 70-year-old lady. She came to our clinic to restore her missing teeth. The first treatment plan was maxillary complete denture and 2 implants on the mandible because we did not have much bone on the maxilla. So we made the complete denture in a traditional method. However, the patient refused to use the complete denture due to severe gag reflex. The complete denture on the screen was never worn by the patient. So we had to revise the treatment plan with implant-supported fixed restoration in the maxilla too. So both lateral sinus augmentation and horizontal ridge augmentation in the anterior were planned. Moving on to the surgical phase. Lateral sinus augmentation was done, and this is a preoperative CT on the left and the right, and we have the panoramic radiograph. We don't have much bone, so we did lateral sinus augmentation. And if we look at the postoperative radiograph, I think we have enough bone right now for implant placement. And for horizontal ridge augmentation, we decided to do sausage technique for the anterior maxilla. This is a preoperative photo we have the CBCT and the panoramic radiograph. We don't have much bone. Actually, this is a very hard situation, I guess. And since we had enough explanation of sausage technique today, it's immobilizing the collagen membrane using a titanium pin and bone graft material inside. So if we look at the preoperative photo, this is on the right and this is on the left. We only have about 1 millimeter thickness of bone. So we did sausage technique, postoperative photo on the right, and this is postoperative photo 2 months after the surgery. And after 6 months, we can realize that there are still bones remaining so that we can go on to implant placement. Digital implant planning was done. I usually make impression with individual tray for these kind of cases, especially like edentulous maxilla where we don't have any tooth, so that in these complete edentulous case, because I think the fit of the radiographic stent and the surgical guide depends on the impression quality. So digital implant planning was done for both posterior areas. It was done flapless. It was nicely done. And for the implant planning on the anterior area, we decided to place 6 implants, including the premolar areas. So the surgery was done again. It was done nicely. And this is the post-operative photograph. However, somebody might have noticed that we missed 1 implant. 1 implant fell into the sinus, and it was removed right after by my fellow surgeon, Dr. An. We removed the implants right away because there's going to be more complication if the implant stays in the maxillary sinus. So moving on to the restorative phase, we first make tentative vertical dimension registration, and we fabricated this bite jigs to set the accurate vertical dimension for the patient. And what I do before I go to the clinic in the lab site, I check that there's passive fit with non-hexagonal connection and that there's no interference with driver use. This is definitely going to save your chair time, and this must be done before you start your clinic. And I made a wax rim in the anterior area so that we can evaluate the preliminary aesthetics, facial aesthetics of the patient. So it was recorded, facial and internal scanning was done. And I thought that looking at the facial scanning data there, I thought that it was very over-prominent facial profile with a wax rim on. So I requested my dental technician, the provisional prosthesis, to be designed with a little bit of lingual shift. And we can see that the design was done with a lingual shift. And the provisional prosthesis was made with screw retain prosthesis. This is her provisional stage. However, there was a problem with the ponic on the central incisor area, so ponic-based modification was done. Waiting for the gingivas to be healed, and the gingiva was nicely healed, and we moved on to the definitive prosthesis stage. Intraoral scanning was done, and bite registration was once more done with the provisional prosthesis on, and facial scanning was once more done. And this is another slide that I request my dental technicians for switching and making modifications for the provisional design. I really think that this is a very important thing that we all must do when we request for a definitive prosthesis. This is the last chance that we can change, and this is what I think the dentist should really do. And these aesthetic factors, they're actually the fundamental aesthetic factors that are for all most of the patients. I know that aesthetics can be very personal, but we have the fundamental basics. So this is, I think, why we need to stick onto the basics. Even though we use digital, digital is just a method, it's just a tool, and it cannot be something perfect without the dentist using it the right way. So definitive prostheses were made, and she now has a rebuilt smile. And to summarize my presentation, I gave you three keywords. First, be a good listener and give an individualized treatment for each and every patient. Every patient is different. Every patient is going to need different treatment, different prosthesis for them. And be the mastermind in the treatment process. We need to be in charge of what we do, and we need to know how it's going, and we need to give information so that technicians don't just give them the data and let them make anyways. They need more information for that. And stay true to the fundamental basics and principles, since digital is a tool, it's a not a cure-all. And I want to especially thank my team of dental technicians. They did a very good job. They did a perfect job. I really thank their contribution. And my fellow doctors, they're my good old friends. They always were very helpful when I always had problems with the patients. And this is my mentor, Professor Jae-hyun Lee. He always gives me inspiration and motivation. I really thank him, and Professor Shiman Park for letting me use his digital devices. So thank you so much.